All right, bro. So advanced right heart echo without sounding like a nerd about it, right? I start with TAPSE and explaining what the words actually mean. Tricuspid, annular, plane, systolic excursion. People tend to not know what the annulus is. The annulus is what connects heart stuff to valve stuff. It's a fibrous ring that connects those two things. You take the measurement at the annulus. And I always say, the numbers are made up. Who cares about the numbers? If you're to measure your TAPSE apically, so not at the annulus, somewhere distal to that, it's going to be falsely low, right? To the extreme. If you try to measure TAPSE at the apex of the heart, it's going to be virtually zero. So when I say on a healthy patient where you expect things to be normal, take the measurement, your TAPSE should be like 2.5 or 2.6. It should be much above the cutoff of 16 millimeters, right? So 2.6 centimeters. I start with TAPSE because that's what any end of first year or second year should understand what TAPSE is. When you get to the advanced stuff, I try to not be a nerd about it. I start with TVS prime, and that's not in your slides, but who cares? So instead of M mode at the annulus, you do tissue Doppler at the annulus, and you'll get a waveform where you measure the top of that. The cutoff for that is 10. But as a concept, if your TAPSE is 26 millimeters, you would expect your TVS prime to be a high number as well. When we talk about how you're going to do TVS prime incorrectly, you're probably going to do it too towards the apex, and it will be falsely low, right? For RVSP, right ventricular systolic pressure, your RV's a wimpy baby, right? When we talk about IVC, the reason why IVC is important is because it approximates right atrial pressures. If it's collapsed, it's 3. If it's variable, it's 8. And if it's plethoric, it's 13, right? Because if the RA pressures are too high, then that's a problem. RVSP is just the ventricle equivalent to that measurement. So the reason why it's 60-60 sign is because if your RVSP is greater than 60, that's a problem because the RV is a wimpy baby, okay? When you make that measurement, you get a good apical 4 view. You're putting color flow between your RA and your RV. And you're looking for a regurgitant jet because you would assume that if you have an obstruction, like a PE, your RV is going to have a big jet because that blood has nowhere to go into the RVOT. So you're doing color flow, and you're looking at the point where that flow is going to be the fastest. And this is something everyone tends to get wrong initially. If you're measuring on the ventricle side of that jet, it is going to be falsely slow because the point at maximum velocity is going to be the point where it just starts to go towards the right atrium. You're looking for a regurgitant jet. It regurgitates into the atrium. So you should be taking your measurement on the atrial side. A lot of these things where people get it wrong, I say if you're too far in one direction, what is the measurement going to do, right? So in TAPSE or in TVS prime, if you're too far to the apex, it's going to be falsely low and you're going to be falsely concerned. Similarly, if you take your measurement of continuous wave for RVSP and you're too far towards the ventricle, it's going to be falsely low because your jet hasn't happened yet. And if you take it too far towards the atrium, it's going to be falsely low velocity because that blood has already started to slow down as it goes towards the atrium. That's why we have to find the single point where that jet is the fastest. So that's RVSP. The last one, and my favorite one, because this is the easiest to get, is pulmonary valve acceleration time. You get your parasternal long, you switch it to a short, and then you angle your probe after you're getting a good short view towards the aortic outflow tract. So you get your RV OT in that view. This measurement, you are doing just proximal, just before the pulmonary valve or the pulmonary annulus. Because if you have two roads in front of you, one of those roads is clean sailing. There's no obstruction. The other road hits a PE immediately. When you measure this acceleration time, the reason why it's the other component of the 60-60, if the acceleration time is less than 60 milliseconds, that is to say, you are going along a road, but then quickly, less than 60 milliseconds, you quickly face an obstruction. That is why the measurement is a slower an acceleration that occurs over less time, because you have less time to accelerate because you're hitting a wall. So those are the different measurements. If you are to take that measurement too far into the pulmonic valve, you're already going to be closer to that wall, right? So even in a healthy heart, if you're already at point where you're almost accelerating the whole way, it is going to be falsely shorter, because you're taking your measurement not at the beginning of the road, right before the RVOT. You're taking your measurement towards the end of the road. So you're going to be falsely concerned if you take your measurement too distally. Again, the numbers are made up. Who cares about the numbers? Somebody could have called it the 80-80 sign or the 70-70 sign. I'm not qualified to make that determination. But thinking in a healthy heart what your measurements are, being able to check yourself and say, okay, my TAPSE, my RV, SP, my TVS prime, my pulmonary acceleration time are all saying the same thing, you're probably right. This is why I stress on you guys to make these measurements on healthy patients, because when you have that sick patient on BiPAP and you can't get your measurements, you've already done it 10 times on a healthy person. You'd never want to do these advanced measurements for the first time on someone who's sick.